Well, thanks everybody for coming out. I am still in awe a little bit. I don't think there's a single chair open. This is an impressive turnout. So thank you very much for coming out. This is awesome. For people that have been listening to me for the last few of these presentations, you'll see that there's a little bit of a repetition of some of the slides and some of the topics. I think a little bit of that is just to show the rate at which we gain knowledge. And so you will see a little bit of that again today. So there's a twist at the end where we have a little bit of newer stuff, but I will be repeating a few things for those people that maybe haven't been listening to all of them as to what actually is the latest, I think, in our field with some of the drugs, especially, and things like this. So looking at some of the questions, I think it'll address a lot of the questions that got submitted ahead of time. So if you bear with me, we'll get to some of those things. And then we still have the Q&A. So feel free to ask questions if something doesn't make sense. Happy to try and kind of clarify some stuff. I can go through it kind of fast, and because I did present some of the stuff before, some of this stuff I'll kind of just hit highlights about it. So don't worry too much about the slides if they have a lot of numbers and things like this. Just kind of listen to me and I'll walk you through them to kind of bring out what I really am trying to kind of show. But I'm one of those people that I get distracted easily. So if the slides aren't there, my mind starts to wander, and this gives me something to kind of at least pay attention to. So if you want to, choose your own adventure a little bit as we go through. All right. I'm a conflicted individual. We work with a lot of the different companies, and so that reflects a little bit of this. One of the biggest chunks I will talk about in the past, we've kind of set the stage as to the new diagnostic criteria. Well, they landed on our lap last month. If you heard some of the presentations about sort of the new diagnostic criteria, spoiler alert, there wasn't a lot of change from what I presented. So a lot of what I'm going to say for the next, 5 or so minutes will kind of be repetitive for people that were listening or were present at the last one. One of the things I will kind of emphasize is a little bit about some of the new imaging markers and kind of hit on those just because it affects a little bit of some of the drug trials. And I noticed that there was a lot of questions around smoldering disease and how we're measuring it. And some of that is kind of looked at and maybe built into these criteria. What I kind of say is a lot of times with our criteria is that they advance very slowly. Each set of new criteria would come in and add in one new thing or one small change. And then this is the list of stuff that got added in at the last time. So I felt like they went around the room and kind of said like, what's your favorite thing? What's your favorite thing? And we got all of it. To some extent, I think it's a good thing. I think this is a lot of the things that we think through when we're diagnosing patients. It's adding more specificity to things. So, we can be more careful in special populations. So in younger and older patients, it adds a little bit of being able to push the boundary as to being able to diagnose MS earlier and things like this. So I think some of this stuff are actually really good changes. When we look at it, this is, kind of typical lesions of what we would normally look at on MRIs. The lesions that we normally would traditionally talk about are the periventricular lesions. You will see that this lesion is ovoid, kind of perpendicular to this black thing. This is where the space where you make spinal fluid. This is the ventricle. And there's little veins that pop through this. And so it added a central vein. If you do a different sequence, now you can kind of bring in those little vessels. And so this is like one of the new things that we tend to see in MS. It can be seen in other things. So a lot of these things aren't necessarily specific, but it's more specific than just when you see this. And so one of the challenges that we're having is we still can't do this very well. We can do it on a research MRI scanner. This past week, we actually started testing some new sequences for our MS protocol. So our MS protocol on the MRI machine is actually going to be changing hopefully soon. I doubt it'll be very soon, just at the rate that things move. But the idea is to try and start adding these type of lesions, for example, and being able to add that and see those better. We'll talk a little bit more about that as we go through. There's lesions that you can kind of see at the surface of the brain. Normally, they like to kind of form U shapes or kind of at the bottom of these dips, sulci in the brain. You can see that this one's a little bit widened around this area, causing some atrophy there. Infratentorial, so the brainstem, here's in the spinal cord. And then the new thing that finally got its due respect, we were expecting this with the last one, was adding the optic nerve as part of one of our areas that can be affected in MS. I mean, it's only 20 to 25% of MS patients that start off with an optic neuritis. So I'm not sure what the delay was in recognizing it as one of the parts for MS. Nonetheless, it got its due. It's finally part of it. And so here you can see sort of a cut that we don't tend to look at very often. But if you came forward a little bit, the eyeballs would be kind of coming in here and here. And this is the nerve going back in. You can see this one's a little bit wider than this one. And so this one has a scar or a sclerosis, some of the damage seen with MS. We talked about one special sequence to look at central vein. The other one that got added was pearls. This one's not used as much, but we'll talk about it for some of the clinical trials as well. So these are paramagnetic rim lesions. And so you can see there's a lesion coming here and it's got a rim coming around it. The sequence that does this and this are sometimes thought to be kind of similar. I mean, they basically pick up metals and it's picking up iron. So in blood, for example, here it's actually blood in a blood vessel for the central vein. Here, it's a type of cell that helps clear up damage and it's picking up basically broken down cells. So these are macrophages. Sometimes our term is foamy macrophages because they look like they have foam in them. Stuff that's in the foam sometimes are red blood cells, which have iron in them. And so that same sequence that picks up iron picks these up. However, these are very different, it turns out. We kept looking at these kind of sequences that we had, and we're going like to the radiologist. It's like, hey, we're not seeing any of these pearls. What are we doing wrong? It's like, oh yeah, those don't work. You have to look at something more specific. So anyway, this is part of the stuff as to why we're changing the sequences around, hopefully in the next near future, so that we can start looking at that. When we start to look at these lesions, having one lesion with this isn't good enough. We want to kind of have a way to identify sort of what does that look like. And so to kind of say, hey, you have a positive central vein sign, what that means, they use a rule called select 6. So this kind of comes about by saying, what they noticed is that if you look at all the lesions in an MS patient, usually about 70% will have a central vein that you can kind of pick up. It's not quite an exact number. If you have lesions that are closer to the ventricle, you pick them up really well. If they're closer to the surface, you don't. There's some minutia associated with it. And if you have somebody that comes in with 50 lesions, you can imagine that trying to go around 50 lesions and figuring out if you have a central vein is not something that's very feasible to try and do. So that doesn't work out well. And so the easiest way to kind of do it was the select 6. Basically, you count around and see if you can find 6 lesions with a central vein. If you can find 6, that's awesome. It's a positive test. If you have less than 10 lesions, then you want half of them to have a central vein. So that's kind of the general rule. So in this beautiful next slide, which we're going to spend a little bit of time, this is kind of what the criteria look like. It's a big table. I wouldn't concentrate on trying to learn this stuff, but it kind of gives me sort of my cues to talk about some of the changes as they come in through. And some of it we've already talked about. So one thing is the optic nerve gets included. So we go from 4 areas to 5 areas. So this is kind of saying if you have 0 areas, what else do you need to be able to diagnose MS? Shocker, if you don't have any areas affected, you can't diagnose MS. So that's why it says not able to make diagnosis. It did push it to kind of, in the past, we needed at least 2 areas affected. So now we can say, hey, if you have 1 area, we can diagnose MS, but you need to meet a lot of stuff to do that. If you have 2 areas or more, then you're pretty much kind of golden. if you only have two or three, you need to add some other things, which includes dissemination in time, meaning you get new lesions. You could have a relapse or other symptoms associated with it, spinal fluid or CSF, and then that central vein sign that we talked a little bit about before. The other column that got added, so this is all brand new, then is for radiologically isolated symptoms. So these are patients that get an MRI for a headache or because they were a research subject or their toenails hurt or whatever other reason that people might get a brain MRI sometimes. And then we were able to sometimes say, hey, you have MS, but you've not had symptoms. Now we can say, based on the MRI, it's, hey, this is MS. We don't have to wait for symptoms. I mean, quacks like a duck, it must be a duck, kind of a thing. And so that allowed us to do that. And so we can, again, kind of look at the same things as far as making that diagnosis. So now we can, big changes on here is optic neuritis is part of it. For people that don't have symptoms, we can make a diagnosis of MS. And it kind of requires that you have some testing that looks like MS to make a diagnosis of MS. So in the past, a lot of times people would have some symptoms and people would just say, this must be MS. And with a normal MRI could be diagnosed with MS. They didn't go as far as pushing that because one of the things that changed a little bit as well was they incorporated a much broader worldwide view. And you can imagine that if you're a neurologist practicing in Africa or, smaller countries that maybe don't have access to MRIs, you don't want to wait for an MRI to make it a requirement to make that diagnosis. But if you have an MRI and it's normal, then it doesn't count for MS. The other thing is non-specific symptoms. So what are the specific symptoms? That's always a little bit hard to define, but you're looking for symptoms that we normally would say loss of vision, double vision. I mean, a lot of other things can do those things, right? There can be strokes of the optic nerve and things like this, but you're looking for things that maybe are a little bit more of what we consider typical, right? So things like fatigue and things like this are common in MS. They're common in a lot of things, and that's where we're trying to kind of separate these things out. Trigeminal neuralgia, paroxysmal events are part of kind of things that can be sometimes typical, but kind of fall in the non-specific areas as far as these criteria go. We talked about the central vein. And then as far as spinal fluid, there were some changes around getting rid of one way to measure positive spinal fluid that didn't work very well and looking at something else. We're still probably relying on oligoclonal bands for the most part. So here, things don't change too much as far as kind of how we would diagnose things, but they just kind of broaden how we can do this. Kappa free light chains is a little bit of a cheaper, faster way. So in other parts of the world, this was one of those things that got added in to kind of make it a little bit more universal for areas that might have a harder time making that diagnosis. As far as MRI, we talked about pearls and then the central vein sign as well as far as this goes. We talked a little bit about being able to diagnose MS if only one area is affected. The main area where this comes in is for primary progressive. If you only have spinal cord lesions, to be able to say, if you have a couple different lesions in the spinal cord, not just one, and you have all of these other conditions, then you could kind of go on to make a diagnosis of MS. So really just trying to kind of, again, push that diagnosis earlier and earlier for certain patients. And then we talked a little bit about special populations. So special populations, and this is the last bit I'll make about this. In younger patients, there's a disease called MOG that in the past, was part of MS, kind of like neuromyelitis optica was. And because it's a population that can sometimes be MOG and not MS, adding that testing became important. So under the age of 12, a lot of times, if you're looking a little bit like MS, about half the times you have MOG and not MS. So that became a very important test to be able to add. If you're between 12 and 18, it just depends a little bit on the symptoms, whether you should do this or not. Our practice is probably that almost everybody's kind of getting that testing done anyway, especially in younger populations. And then in older populations, where you start to have patients who have risk factors for just getting little white spots, you want to add a little bit more umph to the diagnosis. And so that's where you can add it a little bit by adding either if you have spinal cord lesions, spinal fluid, central vein sign. And so where does that apply? If you're older, they suggest 50, have vascular risk factor. So somebody who has maybe a history of heart attacks or something else like this, high blood pressure that's not been well controlled, and things like this, or headaches, because that's one of the big causes for little white spots that we can see as well. And so again, it's just adding a little bit more umph, especially in patients that were maybe concerned that it may not be MS and could be other things. That's what we're trying to kind of do. So there's a lot of kind of like caveats that are being added, but I think it does a nice balance of trying to make a diagnosis of MS and rule out other things. All right, so let's talk about some newer stuff. Except for I got to review a little bit of stuff first. So there was a lot of questions and concerns about tolebrutinib, and we thought we were going to have it. It didn't quite make it out. So it was supposed to come out on September 18th. Or 28th. It got pushed out till December 28th. Not a big deal. I don't know what the issues were. I got told that they needed more data. Why I'm not too worried about it is because pretty much every MS drug, I think, since I have been practicing, has had a 3-month delay. So this is common. I was expecting it might be the case, and it turned out to be the case. And so I think the FDA just moves a little bit slow, and that's just to be expected a little bit. So with that being the case, maybe not by Christmas, maybe a little bit right around that time, we might get tolebrutinib. We did get a little bit of new data. So before we get into the new data, let me kind of just go through a little bit of the BTK inhibitors and maybe why we're excited about them. Just a quick reminder that BTK inhibitors maybe work on 2 different levels. So one of them is to help reduce signaling through B and T cells through this B cell receptor. And so it inhibits this pathway by which these cells can get activated. So this would be a pathway that we would be very excited to kind of work for relapses, for active lesions, things like this, similar to like B cell depletion therapies. In that case, you kill the cell. With these drugs, the hope is that you would just not make them quite as active. The other pathway that we think would be affected some is the pathway of microglia and sort of activating or kind of inhibiting that same pathway by which microglia. This is the part that we talk about, sort of the smoldering, inflammation, and maybe sort of the new aspects that come into it a little bit. All right, so for spoiler alert, it didn't work on relapses. This was the relapsing trial. You can see it was pretty flat. The number of attacks was very low. When we look at progressive numbers, we could see that there was a reduction of 31%. This looked nice. It was kind of a nice change. You can notice that it's maybe not a game changer, right? It didn't go to 0. It's not a flat line. So people are still sometimes progressing on this drug, but it looks better than the other drugs that we have. So I think it's an improvement over especially a placebo type of a condition. And so we'll see a little bit more. If we go back to that relapsing trial, we could see that there's still pretty much a 30% reduction in the events of progression. One of the things I would point out is because these are relapsing patients and how you select patients, the number of events is much lower, so here you can see that only 13% of patients have a progressive event. If we go back, you can see that it's almost 40% that would have an event. So if you pick progressive patients, they'll have more progressive events is the moral of the story. But that effect happens early and we can kind of pick them up. We presented a little bit last time that if you have pearls, those lesions that I was kind of talking about, that it looked like in these trials that there was a better effect. And the more pearls you had, that you had a little bit or maybe a lot more effect on sort of the difference. So not much difference if you had 0 pearls between tolebrutinib and placebo. Placebo patients had more disability, but you kind of stayed stable, if you had more pearls and were on that tolebrutinib drug. So that seemed like it was helpful. And then this is the new data that got presented just last month at ECTRIMS, where we could see like who benefits from this drug. And so this is looking at a bunch of different symptoms or kind of baseline characteristics. And you can see that if you were younger versus older with different cutoffs, older patients actually did a little bit better. So this is kind of telling us that it might have a little bit more of a pure effect on progression as we normally think about these drugs versus the CD20s that primarily worked on younger patients. A little bit of effect, a little bit better on men than women. However, you want to be in North America. I mean, if you lived anywhere else in the world, the drug did not work. But if you were in North America, the drug worked. This is a great example of something that sometimes just happens when you slice the data a little bit too much. And if you find a small enough group and you have a few people that probably just happen, I cannot think of why it would be that much better in the US or North America than somewhere else. So you have to take these things with a bit of a grain of salt. And I just want to emphasize that research is research. You just sometimes have to think through it a little bit. And I can't explain why that would be the case. The other groups that kind of look at it though was, again, this is where now it starts to kind of look a little bit different and look maybe a little bit more like what you would expect a relapsing drug to look like. If you had less disability, it worked a little bit better. If you didn't have disease for quite as long, it looked a little bit better. So for a lot of the questions around patients who were maybe 70 years old and still having progression, would this be a good drug? You know, if we go back to the other slide, you know, baseline age a little bit better if you were a little bit older, not much of a difference. But if we went back and kind of start looking at, you know, if you've had disease for more than 10 years, it didn't quite look as good as if you didn't have disease for that long. And so this is the part that we're just kind of like trying to kind of sort out and kind of say, okay, where do we want to use this drug? If we use the drug when patients are really early, very young, they're not going to have a lot of relapses, or they're not going to have, you know, there's a better chance of having a relapse. And if it doesn't work on relapsing very well, then we're going to run into issues, right? Because it doesn't work on relapses. The other thing I would mention is that if you had enhancing lesions, it looked much, much better than if you had no active lesions. These were primarily the patients that also had pearls. So this is a little bit why we're trying to get that pearl sequence up and running, because I think that's going to help us try to sort out maybe who might benefit from the drug and maybe not so much. So more to come. Again, there was a liver issue. One patient did die. It's probably going to require weekly labs for the first 3 months. So this isn't a drug that I would say, we'll just try it and see how it goes. We want to kind of have a good sense as to who might benefit from it. This drug did not do much as far as affecting immunoglobulin levels. We worry about this with CD20s. It did not affect lymphocyte counts much. So, you know, if we think that these are important and this is kind of how it works when it affects B cells, that might be part of the issue why it didn't have an effect on relapses. So if we look at the phase 2 study and why there was so much excitement was you could see early on, this was only a 12-week study, is that the number of active enhancing lesions went down. But you saw that about 20% of patients, these are the bars that show how many people did not have an active lesion. And over time, 20% of patients still had enhancing lesions. And what happened was is that the patients, after different doses of drug and were kind of maintained on things, everybody got switched over here. Patients continued to have enhancing lesions. So on tolebrutinib, this is maybe part of the reason that even though we theorize that it has an effect on B cells, it doesn't look like it really did. So it works sometimes in little Petri plates. It works in the lab. When we go test it in humans, we find out that that's maybe not the same, right? And mice are different than humans by a little bit. And so, we have to do those experiments a little bit in humans to figure out what the issues are. All right, I'm going to flip over to fenebrutinib. This is another drug that we will be hearing about very soon. But just to highlight that these number of lesions goes down, and then notice the difference. It looks like it does stay down. So we're seeing that it looks a little bit different from tolebrutinib as far as enhancing lesions and T2 lesions. Look at the difference as far as B cells. So B cell counts actually drop almost by 50%. Immunoglobulin levels are actually going down, and they look a lot like the effects that we would normally tend to see with B-cell depletion therapies. So this gives me hope to kind of say this drug might have an effect on relapses. There's no data at all on progression, so more to come when that comes up. And I'm running over time, but I'm going to take a couple extra minutes, so sorry. Where are we at with studies with BTK inhibitors? So more to come probably in the next few months. There's also remibrutinib coming up. This is from Novartis. They are still recruiting their trials, so it's probably going to be several years before we still would hear anything. BYB091 is in our phase 2, and that's a Biogen drug, so more to come on that a little bit. All right, so that's where we're at as far as BTK inhibitors. I also said that there was trials coming up on higher doses of ocrelizumab. The rationale for that was because in patients that, when we looked at sort of dosing, we couldn't change dosing because everybody got the same dose, but smaller people got more drug per body weight than a bigger person did. And so in smaller people, we could see that, in bigger people, we could see that B cells kind of took a lot longer to get depleted or come up to zero. It worked no matter what dose you look at it for relapses using or MRI outcomes here, but on disability, it was kind of the small people that did much better. See, it's farther away from the other group. And so, there's a trend to kind of say, hey, this looks real. However, you do the study, right? So we have to do the studies. When we talk about, hey, I saw some report of, vitamin XYZ working on this, right? It can be great in mice and in the lab, but why we do the experiment? Because when we do the experiment, we showed that high doses do not matter. Those two lines look about as superimposed as they did. And so this has kind of been dead in the water as far as looking at the high doses. So this is the progressives trial. Last time I talked a little bit about the relapsing trial. For that one, progression also looked like nothing. So higher doses do not seem to matter at all. There was another trial that looked at progression called Oratorio Hand. And for this one of the things I point out is that they required people to have active lesions. We know that B cell, and this is a trial with Ocrevus in primary progressive patients. Think about this as sort of like similar to the trial that they had already done. But because there were so many questions about aging, this trial actually went up to age 65 compared to 55. The EDSS, that disability, now included people in wheelchairs. It was trying to use hand function. And what we can see is that the drug worked. The effect was very similar. The age did not change much, but there were patients who were much more disabled when we look at the EDSS here. Didn't realize the cursor wasn't working, so sorry. The EDSS was a little bit higher when we kind of compared these two studies compared to the prior study. I bring this one up a little bit because in the original trial, the difference was a reduction of 21%. And we might say, oh, 30% with the BTK inhibitors with tolebrutinib is so much better than 21%. If we play with the conditions around the trial, we can get a 30% reduction. So in this trial with older patients and things like this, but still maintaining people that had active disease, we can get kind of a similar percent number. So as far as kind of saying that tolebrutinib is better than B-cell depletion as far as disability goes, words of caution. We're still going to have to see what this looks like in hands in the real world a little bit compared to these trials. I'm going to skip that and this. Frexalimab was another drug that got presented. This looks good. It got presented for 2.5 years. It dropped levels of everything you would measure, and it looked good from that perspective. I'm going to skip a little bit about CAR Ts, but I wanted to talk a little bit about this combination therapy. This was a combination of metformin and clemistine. There were several questions on this trial. The idea was, hey, in older patients, the cells that cause remyelination by clemistine maybe don't work quite as well. So let's make them younger by using something called metformin, which had been shown in the lab in plastic plates to be effective in doing that. And so the rationale was like, let's do something that can cause remyelination and things like this. This was based on a study that on clemistine, you could modify and improve on something called a visual evoked potential, a small effect that patients didn't notice that they actually saw better. And unfortunately, this combination of therapy, this is what the study looked like. It took a lot of patients to get in. So they screened 178 patients to get 70 patients because they were looking for just the right patient that would benefit. And what they found out was an improvement of 1.2 milliseconds, so even less than what the other one had seen. So I wanted to show this study a little bit to kind of say, hey, there's a lot of efforts happening in remyelination. We're trying, but this combination did not seem to make much of a difference as far as actually improving outcomes. This is a complicated slide just to say they didn't see something as far as people being able to look at a chart and seeing a difference as far as that goes. And so I think with this, we can turn it over to the Q&A. All right, sounds good.